see tricuspid abnormalities, pulmonary intact ventricular septum, septal defects, AV valve abnormalities, problems with the crux of the heart, pulmonary venous problems, and the structures around the heart like pericardial effusion of significant in nature, cardiac mass or abnormal rhythm function related to cardiac rhythm or cardiomyopathy. So I thought of showing you some clips and then we can see some examples. So here in this example, you could see posterior spine, posterior abdominal aorta on the first. Then you're seeing the pulmonary veins connecting to the left atrium, if you can point out, Abdullah, and there is a atrial septum. And you see the right heart, which is the anterior structure, is normally developed. However, the left heart is LV is small. So this is your hyplastic left heart. So, and again, another example of your hyplastic left heart with the EFE and a foreshortened LV apex. So very common cause is aortic valve problems, aortic stenosis and aortic atresia, which is in 2/3 of the cases. Followed by mitral atresia and mitral valve problems. Yeah, next one, please, actually. So next slide. So I think this is the same example to show you on the color. So move on, please. Next one. So when you come to the outflow tract, I think it is important to look at it in a side by side, but although it's not truly 4 chamber. So what you're seeing is a 2 vessel after the right SVC, and there is a aorta missing, which is you got a flake of red retrograde flow into the aortic position, but you got a big pulmonary artery, pulmonary trunk there, yeah, which is a ductal arch. Yeah, next one, please. So so it is about 2 to 3% of your complete fetal cardiac series, and we know about hyplastic left heart, and as I said, majority of them are due to aortic atresia, and about 5 to 6% of them are due to mitral atresia in this case. So assessment, once you've done the diagnosis of hyplastic left heart, it's important to assess the forward flow, aortic valve movement, if the aortic valve is still showing forward flow, and try and get size of the aortic valve. And on the 4-chamber view, it's important to assess. In this particular example, you could see the PFO is restrictive. And it's a continuous flow from left to right, and the LA is getting prominent. So it's important to assess with the pulse Doppler on the pulmonary valve, pulmonary vein. You can see the normal systolic, diastolic, and a small atrial contraction kick, which is a small reflection, which is normal. However, in a restrictive atrial septum, the next sample it shows like a to and fro with a large reflection into the pulmonary artery with the pulmonary congestion. So this reflects your poor prognosis in a hyplastic left heart syndrome setting. Next one, please. So I leave this counseling to the next topic, but these are all the general, counseling setup we go once we've done the diagnosis. So your options are palliative surgical options versus compassionate care if the family don't want, or if they think of termination. Each family is different. All the options we go through, and we go through amniocentesis, and we normally follow them at least twice, if not thrice, depending on the atrial septum. So next is an example. Here you could see on the 4-chamber view, which is an important finding, which you see RV-LV disproportion. However, this LV is functioning well. LV is apex forming. Mitral valve is functioning well. And if you assess the outflow tract here, the LVOT, carefully size the aortic valve and size the forward flow. And similarly, try and assess the outflow tract views as well as the 3-vessel view to see association with hypoplastic arch. So it's earlier, the gestation presentation like this is difficult to reassure. So you got to be open with the family in terms of this may turn into a hyplastic LV or a borderline LV, or this could be just arch problem, which may be fully correctable and leading you into biventricular circulation. Later gestation, if you see these findings not been there on first trimester, the second trimester, but in third trimester, if you just see this one, then it could be associated normal finding as well, where you see postnatally things get corrected on its own. Okay, so next one is an example you could see, it's a right heart pathology. So as you can see, posterior aorta and posterior LV. Your posterior chamber is good size, which is the left ventricle, and your anterior chamber is small, which is a hyperplastic RV, and there is no tricuspid valve connection above the RV you could see, and RV is connected through the VST. And if you look at the next side view, the second picture here, see the RV is giving rise to here what it looks like is you need to ascertain whether is it branching or it looks like it could be TGA and aorta. Both are possible, or it could be normally connected vessels. They cross over normally, but you got a smaller vessel coming from the RV. So this is a tricuspid atresia with a hyperplastic RV right heart pathology in example. Next one, please. So again, so it's about 3% in the fetal series. So things like are important. Usually, you'll have a good atrial communication in this situation, but sometime it can be very rarely. It can be a problem. So where you could have early problems like hydrops and failure in the circulation if that's the case. But it's a usually you'll have a good communication in this scenario. As I said, it can be associated with TGA. It can be associated with other outflow tract abnormalities. Genetic association and extracardiac association is very small in this percentage. Yeah. Next one, please. So here is another example of, so what you're seeing is a posterior chambers, they're all good, and LVOT is good, but you got a significant, if you look at the inflow view, so you got a significant leak from the tricuspid valve, and so your RV is looks slightly, foreshortened. And what you're seeing on the 3-vessel view, when you come up, there is a retrograde supply, there is a red flow opposite to your aortic flow. Um, So this is a pulmonary atresia with the intact ventricular septum. Yeah, next one, please, if you can go to. So again, we know the various scores in postnatal series. So they can, if the RV grows into bipartite or tripartite, then we could attempt to do balloon and repair and try and establish a biventricular circulation. Failing that, they will end up having single ventricle circulation with the hyperplastic LV. And again, genetic association is very rare here. Yeah. So here is an example of, again, 4-chamber abnormality. What you're seeing is a double inlet ventricle. So you're only able to see one big ventricle, so often LV. The anterior chamber is often connected through VST and with a small chamber. Again, outflow tract, it can be associated with any different association. You can have DORV, or you can have normally connected, or you can have TGA association with outflow tract abnormalities. But just with the 4-chamber view, you can pick up this abnormality reasonably well. Next one, please. So DILV is very small percentage on the fetal series, and again, very small percentage of association with the chromosome abnormalities. And the postnatal outcome on the single ventricle route on this group. Yeah, next one, please. So here is our example of our common AV septal defect, which is apical 4-chamber, balanced ventricle, moderator band, anterior RV, posterior LV, common valve. You got a VST below the valve and a ASD, primum ASD above the valve. And here you're seeing a normal distance between your aorta and the LV posterior chamber, and you're about to see the pulmonary veins opening into the left atrium. So there's nothing else suspicious. The cardiac size is good. So you do the color assessment to look for AV valve regurgitation in this scenario. Then you go for the next outflow tract assessment in this situation. So next one, please. So 3 to 7% of congenital heart disease, about 13 to 15% on fetal heart lesions. So we know that it's up to 50% associated with trisomy 21. If you see atypical, like a complex AVSTs, then there are more association with the heterotaxy and isomerism in that group. So it is important to assess the outflow tract separately, carefully, as it can be associated with fallows, TGA, DORB, coarctation in this situation. And again, here you can see this is intermediate AVST, you could call, where you see a tiny portion of primum septum, but you can see there is offsetting is missing here. The IV walls are in common level, and there is an inlet VST, which is, so this is still a complete AVST with a, you could call it as intermediate with a large VST component, but atrial component is maybe attached by the bridging leaflets in this situation. Yeah, next one, please. So when you start seeing like this, it's worrying AVST, where you are coming into unbalanced or single ventricle complex AVST scenario. And you also see the distance between aorta and the posterior pulmonary chamber. So you got to ascertain a bit more carefully here. Next one, please. And here you could see a confluence behind the left atrium, and you need to try and see where it is draining. Is it draining directly into the right-sided atrium? In that, it could be associated in this situation, right atrial isomerism. If you see on the bicaval in the situation, interrupted IVC, then it could be associated with the left atrial isomerism. So it's a single ventricle physiology here with more complex heterotaxy syndrome in association. And it's important to work with fetal medicine unit here to look for other associated extracardiac anomalies, abdominal pathologies in this situation. Isomerism is 1/5 to 1/4 common association in this scenario. Yeah. And prognosis is going to be very poor here. So another important condition on the four-chamber abnormality is Epstein's, is a very small percentage on fetal series. So you see the anterior chamber where the septal attachment and migration of the tricuspid valve, and it is enlarged. I think the next one, if you go to, if you yeah, so still in Epstein. So it gives epsteinoid a displacement of the valve, and you could see the whole cardiac dimension, cardiothoracic ratio is very big. So earlier the presentation in this scenario with the leaky valve or with associated heart rhythm problems, with they are kind of associated with poor prognosis here. Meaning you can have high drops and fetal loss in early presentation or clinical scenario. So this is another example of for similar right heart abnormality, where you see your offsetting is maintained and your tricuspid valve attachment is maintained, but it's quite a leaky tricuspid valve dysplasia rather than Epstein's here, so which is causing a very huge right atrium in this scenario. Yeah, next one, please. I think the prognosis is somewhat similar to Epstein here again, because it's going to the right. It's earlier presentation and worsening, cardiothoracic dimension, cardiac rhythm problems, high drops, pericardial effusion can all be associated in this scenario. Next one, please. So this one is an example I'm sure you can appreciate here. So your posterior pulmonic atrium with the pulmonary vein connection is connecting to your posterior right ventricle morphologically, and your anterior systemic atrium is connected to the left ventricle. And on the right side of the picture, if you try and look at the outflow tract, the left ventricle is giving rise to pulmonary artery, and your right ventricle is giving a parallel vessel of aorta. So next picture, please. So this is CCTGA with the balanced circulation and with what it looks like intact septum, where you can see here the LV is giving rise to pulmonary artery, which is branching. So reverse offsetting, AV double discordance, parallel great vessels. So again, prognosis depends on if the circulation is balanced, I mean, they come out reasonably well with no major issues, but they are prone for heart rhythm problems, heart blocks, associated problems, VST, pulmonary valve abnormalities. You could have unbalanced ventricles. Some, may lead on to single ventricle circulation, and tricuspid anomalies and epistenoid anomalies are common association here as well. Very rare to see extracardiac or chromosome association in this scenario. Next one, please. So anomalous pulmonary veins, as I said, like it's very difficult to pick up if you have a structurally normal heart, and particularly where your pulmonary flow is, going to be less than 10-12% in the fetal circulation. So you don't see the typical right heart enlargement and all the features what you see postnatally, but you can suspect, if you're not able to see two pulmonary veins, or if you have complex AVSTs like this here, single ventricle scenario, and if you see any confluence of chambers behind the left atrium, or if you see a long distance between the aorta and the posterior left atrium, where you can suspect. And you can try and assess the connection, is it intracardiac, supracardiac, or infracardiac, but however, it can be challenging in the fetal circulation. Next one, please. So this is an example of your muscular VST, simple muscular VST with a balanced circulation. I mean, a lot of the time you may not see this one by the time baby is born, or it can present, but this is a small VST, an example for you. Next one, please. Yeah, but we know that, it's got a higher association with extracardiac anomalies like charge and vectoral other associations, as well as chromosome associations. So this example, you could see carefully. So your four chamber inlet view looks normal, but as you kind of come out to the outlet, so the perimembranous area, there seemed to be a defect below the aortic wall. So this is a perimembranous VST with a balanced ventricle scenario. Yeah, next one, please. So an example, as we talked before, so this is, you can see the situs view shows abnormal asagas as well as your abdominal aorta, both on the left side, and you got a heart block on the cardiomyopathy. So this left atrial isomerism, interrupted IVC scenario. Again, heart block, high drops, pericardial effusion, early gestation, they're all poor prognostic sign in this association. So here, if you go back, so this right atrial isomerism. So here, what we are seeing is there is a large distance between aorta and posterior pulmonary artery. So I don't have a running clip here, so it's just a still. So you can suspect pulmonary venous confluence in between that area. And again, if you look at the great vessels, the aorta is posterior to the IVC, and both are lying on the right side. So this is a right atrial isomerism, higher association with congenital heart problems in this scenario, and also higher association with the IUD and type of intrauterine complications in this scenario. Yeah. So just an example, I think you had a full topic of fetal rhythm problems. So again, it's important finding that you get in four chamber abnormality. The top abnormality is, you could see that flutter SVT scenario, and the bottom is your complete heart block scenario. So cardiac tumors is another very small percentage, about less than 1% of fetal cardiac findings. So as you know, rhabdomyoma is most common finding. So once you find it, once you suspect, you go and start investigating on the TS gene route in this scenario. But you could also have other not common tumor abnormalities, as well as uncommon malignant tumors as well. So what is important in assessment here is rhythm, as well as the inflow-outflow tract obstruction, and are they kind of potential for obstructions. If they are very huge tumors, multiple tumors, then you have a very high risk of, like obstruction and fetal loss, where you could, there are some of the cases, we have discussed, and we have, particularly in rhabdo, we have thought about antenatal, cytotoxic medications trial, like sirolimus, tacrolimus, but again, with a varying response in this scenario. So last slide on the four chamber abnormality is cardiomyopathy. is again a very small percentage. So where you could have a dilated cardiomyopathy, which is more common than the hypertrophic cardiomyopathy association, is anything simple from a fetal anemia or hemolytic anemia scenario or torch infection scenario, or you could have sometime twin to twin association sometime can give, or you could have true cardiomyopathy, like where muscle disease relates secondary to metabolic as well as genetic mutation situation. And also sometimes you do see cardiomyopathy related to rhythm problems. Hypertrophy is Noonan's genetic exome defects and storage disorders. So to complete the four chamber abnormalities, so these are all the checklist. I think I already talked about all of them. So you can go through this again. What is important is meticulously go through one by one before you declare you got a normal heart situation. And if anything is suspicious, you try and bring them back into for a follow-up. Okay, what is important is particularly if you're offering early trimester or the excursion of valve movement, if they're all not very clear, it's important to bring them back, 4 weeks, 6 weeks at least, to make sure that it's not developing into aortic valve scenario or mitral dysplasia scenario. So swiftly move on to our outflow tract abnormalities. So this is a checklist. Again, it's important to go through this meticulously one by one. So how is the connection between the LV/RV to the corresponding outflow tract, or is there a normal proximal crossover at the origin site, or are they parallel vessels? And the size of the vessels, are they in comparison equal size? And how the valves, individual valves, pulmonary valve, aortic valves, how they are moving? Do you see antegrade flow with a normal Doppler velocity, or are you seeing increased Doppler velocity more than one in fetal circulation? You start worrying. Or reverse flow situation. So this is some examples of outflow tract normal views, where you see the middle portion is very important, the middle clip, where it shows the LV interventricular septum and its continuity go back to the aortic valve. So where you'd see continuous continuation of septum to the aortic valve. So if that's important to rule out outlet VSTs in this situation, and you see the aortic valve size and the Doppler here, and the ascending aorta, you get an idea. So similarly on the pulmonary artery on the third clip. So three vessel view, again, correspondingly, it will show what abnormality you are suspecting from your LVOT and RVOT views. So SVC, aorta and pulmonary artery on the first clip. And again, when you go slightly high up as to the tracheal level, you see them both joining the ductal arch and the true arch, forming into the descending thoracic aorta. Yeah, next one, please. Yeah. So sagittal view is important in terms of you assessing, confirming what you suspect on the three vessel view, particularly arch problems, interrupted arch problems, or isthmus, suspicious isthmus narrowing, or if you see single outflow tract, how is the ductal arch? So which is the first straight going posteriorly, the pulmonary valve to the ductal arch, which is often directed to the spine, whereas the true arch is forming more curvy with the head and neck vessels coming out of that. So these two views are important. And obviously, sagittal view is going to be useful for other things like your branch pulmonary artery, right pulmonary artery, your IVC, SVC, how they are connecting, like a bicaval views scenario. So so these are all the clues, like as I said, like any discontinuity or any size discrepancy, any not crossing over great vessels are all going to give you a clue that you are suspecting potential abnormality in your echo assessment, fetal echo assessment. Next one, please. Yeah. Yeah, so some example conditions like Fallows, pulmonary VST, outlet VST, truncus, TGA, coarctation and arch problems. So these are all the ones you're going to suspect. So here's an example echo clip here. So where you're seeing overriding aorta between the two chambers. And if you look at the end of the clip, so you see the smaller pulmonary artery arising from the anterior chamber towards the end of the clip, actually. You have one more example, probably. I don't think. Yeah, that's a pulmonary artery. It's a normal crossover. So here is a Fallows I think this one. Next one, please. Yeah, so again, we lost the video. Abdullah, we lost the video, so
Yeah, I'm just trying to bring it back up. Sorry. Nope. 1 minute. Can you see it?
yeah. So you just it's gone again.
Yeah, 1 second.
You want to share the screen fully.
Yeah. Yeah.
Yeah, so fallows here. So you got higher chromosomal association, particularly discharge, and higher association with the right aortic arch. And you're going to have all variants of fallows from normal fallows to pulmonatresia and absent pulmonary valve. So what is important is we normally see them twice, sometimes thrice, depending on what you're suspecting in this scenario, and they give them a careful delivery plan and postnatal echo before they get discharged. And it's more association with the charge and vectoral association here. This is an example here. You see the normal 4-chamber view. You get a hint of right heart dilatation, but if you look at the outflow tract, so there's a fallows with the absent pulmonary valve with the to and fro flow at the pulmonary valve level, and you see huge dilated main pulmonary artery and branch pulmonary artery. So we know that it's a quite a tricky condition to counsel and to give reassurance to the family, because it can be associated with lung issues, airway issues, Malaysia. Earlier, the lung vessel is going to be dilated and impinge on the growth of the trachea. More higher the abnormality you can anticipate at the time of delivery. So that's absent pulmonary valve fallows. Yeah. Next one, please. Here again, VST overriding aorta. But what you're seeing is at the position of the fallows, sorry, RVOT outflow, you see a red flow coming towards the RV. So this is the fallows with the pulmonatresia type of pulmonatresia presentation, which you can suspect here. So see that. So it's supposed to have same direction flow. Yeah. And also small pulmonary artery. So then you had to go and confirm your 3-vessel view and where you should have reverse flow at the ductal arch here. Yeah, next one, please. So here is another example, pulmonatresia VST, where your pulmonary valve is membranous, and you see the branch PAs, they're attached to the main pulmonary artery, but there is no connection to the RV. Yeah. So this is as you come to the 3-vessel view. So when you see these 2 vessels, this is an important sign that you start worrying. So lots of differentials as you see the still at the 3-vessel view. So what you're missing is the second outflow. So here you could say your arch is missing, or is it the pulmonary artery is missing? So the scenarios can be like pulmonatresia, or it could be like a 2-vessel view when it's anteroposterior parallel vessel, so it could be TGA. So then you connect this 3-vessel abnormality to your outflow tract abnormalities. What you're seeing there is a overriding vessel with a thick outflow tract valve. And again, if you carefully look at it, next to the outflow valve, there is a pulmonary artery which is starting. Yeah, so to the about 9 o'clock position. So yeah, so that makes it suspicion of truncus in this scenario. Yeah, so play this one. So normal inflow. So as you come out is an outflow, then you start seeing the posterior main pulmonary artery, which is attached to the aortic root. So truncus arteriosus here about 1.5% of congenital heart abnormalities, and is higher association with your discharge syndrome and extracardiac abnormalities. And we know all the types of truncus between from 1 to 4, and it can be associated with the right arch, and it can be associated with multiple quadricuspid or dysplastic truncal valve. So depending on the severity of what you see, your counseling as well as your postnatal plan for delivery is going to be. Yeah, next one, please. Very rarely, I mean, you can see truncus with the interrupted aortic arch, a duct-dependent arch situation. Although by definition in truncus you don't see the duct, but we have come across few interrupted arch with the ductal arch. So this is an example where you see the right ventricle is giving rise to a big blood vessel, so which is a double outer right ventricle situation. So you have to look for, hunt for the second vessel, which can be anteroposterior, parallel in this situation, or it could have atretic or small pulmonary valve or small aorta, depending on all the associations are possible. As we know, DORV can be, related to different levels of association with the VST, subpulmonary, subaortic, doubly committed, non-committed VSTs, and it can also be associated with other problems like AVST, DORV scenario. And you expect a normal relation up to Malpos to TGA vessels here. So what you're seeing here is a normal 4-chamber, but as you pan up to the outflow tracts, you're not seeing the proximal crossing of the vessels in this scenario, and that is supplemented by your sagittal arch view. So this is a typical example of transposition of great arteries with intact ventricular septum. So yeah, next one, please. Yeah, so we all know different scenarios attached to the DTGA, and we do a special delivery plan and postnatal careful planning. So we do see TGAs 3 times at least in our fetal follow-up, mainly to assess the atrial communication and any restrictions developing as the child advances into third trimester. So this here you see the parallel vessel, and at the top you see the 3 vessel abnormality where you are supposed to see next to the SVC you expect the arch, but here you got a pulmonary artery and your arch is on the other side here. So this is a TGA with the parallel vessel and abnormal 3 vessel, but as you go to the 3VT in this scenario, you will see 2 vessels commonly in this scenario. And associations, like you could have pulmonary stenosis and multiple VSDs, or these are different scenarios. So arch problem we have discussed before. So unbalanced ventricle, but apex forming LV. 3 vessel shows typically SVC, and aorta is which is in between ductal arch and SVC, which is small. And when you assess with the color, you can get varying presentations from forward flow from the aortic valve, or reverse flow if it is associated with a serious subaortic or aortic pathology. So this, yeah, so this LV, which is giving rise to Abdullah, are you able to play? So aortic valve, which is, you can see it is plastic and it's leaky and it's stenotic with a post-stenotic dilatation. And but here your careful assessment shows your LV function is reasonably preserved and your LV is apex forming. What is important is to follow them up to the third trimester and see how this LV is developing into. The next one, please. So it can develop into a scenario like this, where you have an aortic stenosis, which can get into critical aortic stenosis. Then it can lead on to EFE and hyperplastic left heart scenario. So we all have come across postnatal scenarios of this, where next one, please. Your management is going to be very tricky. So it is prostate-dependent circulation. So the long-term prognosis is going to be depend on the LV as well as mitral valve, how they're going to support, even if you balloon the aortic valve. And there are various strategies of management we have discussed, and we have gone through by MRI assessment and hybrid situation. So, so I mean, recent papers you could see on the fetal interventions, particularly for these type of scenarios, where you could do a fetal potentially fetal aortic valve interventions. But next one, please. So the highest number is so next one, please. Next one. is sorry, one before. So it's done, as we know from the sorry, go back, go back. Yeah, see the yeah, the circulation paper. Yeah, so Wojciechowski, they got the highest numbers now, about 143. That's the latest 2000 report. And what they're saying is about 50% of the circulation, I mean, interventions they have achieved biventricular. But what they are coming out with is modest medium-term survival benefits of biventricular. What is important here is appropriate fetal selection and intervention between 21 and 30 weeks. And there are various assessments of your LV, your septal flow from left to right, your aortic forward flow, and they claim that there is no maternal risk and a very small risk of fetal loss in this series, but it is still not, much reassuring in this as fetal intervention. So next one, please. But so UK, what is UK's position here is so NICE has given 2018 that it's still practiced as a research level, and it's only done rarely in the UK. This is fetal balloon aortic valvuloplasty. So this is an example of pulmonary valve pathology parallel to the aortic is on the right side. So where you see dilated pulmonary artery and the turbulent flow from the RV to pulmonary artery with the post-stenotic dilatation scenario. Next one, please. So so three vessel abnormalities. I think we have gone through this. So you could pick up more abnormalities, like as I think Caroline has covered this topic, like all the different arch problems, hypoplastic, interrupted arch, or right aortic arch, double aortic arch, or aberrant vessels. These abnormalities, can be picked up in three vessel views. So you could, what is also important is you expect, what you have seen on the four chamber view. So if you have abnormal four chambers, then you expect the corresponding abnormality. So if you have a normal four chamber, then you could have one of these scenarios where you could have right aortic arch or double aortic arch type of potential, vascular ring scenarios, not necessarily all of them are vascular rings. Yeah. I think is that all. So this is, I think I conclude with that last double arch scenario, which is, I think, normal intracardiac anatomy, but you could have right arch and left arch, both are persisting. What is unknown is by the time this fetus is delivered, are both arch going to be persistent, or is one going to become fibrotic? So these are all the potential possibilities, but you go through all the scenarios with the counseling and put a careful delivery plan in this situation. Yeah, so I think that's it. Thank you, everybody. So I think it's I rushed it a bit. Sorry for the rushing. So it's two big topics, four chamber and outflow. But the message, what is important is segmental sequential analysis is very, very important, starting from your situs to four chamber, then outflow tract, then three vessel, and the sweep technique is again very useful in the scenarios. If you can get that will kind of give you the final diagnosis a bit more in a reassuring way. Any questions?
Ram, another fantastic presentation from the fetal team. I think a huge topic, as you said, and it didn't feel like you were rushed at all. I think you covered everything in a good amount of detail. Again, to us surgeon types, it's a lot. I mean, we're learning with every picture you show us, but a lot to take on there. But fantastic presentation and overview of a huge topic. Thanks again.
Cheers. Thank you, Ramesh.
Thank you, Ram.
Yeah.
I think
Anybody
it was
else?
very well.
Ram, it's Ram again.
Hi,
Excellent presentation. But do you have any data of, the hyperplasty you diagnose? How many of them get terminated? Any data available?
We have on our local women's database, we have for our local data. I think we had to go back to Joyce's presentation. I don't have it in hand at the moment. Sorry. But we have in our audit just for the Liverpool women's side. Yeah.
Women's, okay, yeah. No, that's fine, but excellent. But it's amazing to see what you can see, the fetal heart. I've never seen that impressive images actually. It's
Yeah, it's the same amount of pathology you can anticipate to see and go through the scenario. So, but yeah, it's quite a vast scenario as well. Yeah, thank you.
in terms of comfortably giving the parents, at what stage or what age, gestational age you think you can make a lot of these diagnoses?
The-
The earliest is, as you said, 18 weeks to 22 weeks, isn't it?
Yes, yes. So 21 plus 6, 18, that's the maximum. I mean, that's the time you get to see maximum, what do you call, anomalies and resolution of the cardiac tissue. And it's a compromise between, so if you wait too long, your further fetal growth takes over and it starts putting, rib shadows and baby shadows. So you might start losing what you can potentially identify before 22 weeks. So up to 22, 23, 24 weeks, you could see and give them full diagnosis, and that's the ideal time. But some of them, as I said, like early first trimester scan, we do see, we do get do occasional, like a 14 weeks, 15 weeks. These are all like for our hyperplast who lost the previous child, or major congenital heart problems, or major NT thickness, but we still need to see them between this 18 and 22 weeks window to reassure. And again, is a same scenario. Like if something is suspicious but not sure, even on 22 weeks, then that needs follow-up. So for example, aortic valve scenarios or mitral valves. If you see the excursion of the mitral valve is not good, or if you see there is a subtle LVRB disproportion, then we bring them back. At least a good 6 weeks apart to see, along with the fetal circulation, are the chambers changing, or the valves developing into more sticky stenotic scenario. Yeah.
Ram, it's
Okay.
Arul here.
Yeah,
Thank
Arul.
So,
Arul.
yeah, I mean, while I was a trainee, I didn't see this good pictures. Is that because the machines have gone better or the
Who trained
cardiologists
you,
have
Arul?
got better? I'm not going to tell you that. But I was going to ask you, with these good pictures, do you still think cardiac MRI is something which should be done? If so, what kind of patients do you think cardiac MRI is needed?
That's the scenario I think we have discussed on few times, Arul. So it is not widely practiced at the moment in everywhere, but MRI has got definite role in very tricky scenarios, like like if you have at the moment in Liverpool women's, it's done for other problems, like for example CDH, or lung pathology, or cranial pathology, where we do ask them to look for other additional thing. But the cardiac is not done in Liverpool. But if you go to the St. George's and the Evelina series, they're doing more on the research basis. Definitely, if you, I'm sure if who's here, he could give us a bit more insight. So if you, the tricky bit is like the fetal movement and the fetal heart, and try and get the maximum resolution MRI. If you get it, yes, I mean, you can pick up, there are papers, many papers, they are supporting that more arch anomalies, more vascular abnormalities can be picked up in cardiac MRI situation. And
But
also, sorry.
it looks like you're getting everything on echo itself. You got excellent pictures. Maybe it's obese patient or something. Is that done in
Yeah, I mean,
Liverpool
like,
itself? Liverpool women's?
we don't at the I mean, like as I said, like the cardiac MRI is in fetal circulation is not an easy standard way of acquiring MRI, but I think it's the techniques and the protocol needs to be done in the right way to overcome the fetal movement, small fetus and fetal heart. So if you don't acquire it in the right way, then you may not get the right information. So one few cases, like Caroline has definitely said, Joyce has definitely said, like nutmeg lungs, lymphatic abnormalities in a intact septum hyplastic arch. So we have sent very rarely, few cases. I think Evelina and St. George's, they have derived a protocol on cardiac MRI in fetal heart.
Okay, great, thank you.
Yeah. Okay. Is it all? Shall we call up for any other questions?
No, I think that sounds like it's the end of that. No, thank you very much, Ram. They've been fantastic in taking the time to put together all these presentations and coordinating the the schedule. Much appreciated.
Thank you, Ramesh. I think the next one will be your final talk on fetal based on cardiac specialist nurses. Darian House and Joyce is going to take you through some difficult scenarios in counseling. So look forward to that. I think it's coming in first week of August, if I'm right.
Yes.
Garima will inform that.
Yeah, that's on
Good
the
stuff.
4th of August. Yeah, thank you.
Excellent. Thank you.
Thanks a lot. Thank you.
Bye.